Good afternoon, everyone. Welcome to the Illinois Tech Social Sciences Great Problems, Great Minds Seminar Series. For today's seminar, you can submit questions during the webinar by typing in the chat box. We will open the floor to questions at the end of the webinar. Today's speaker is Professor Chen. Dr. Chen is an associate professor of public health policy, of global health, of economics, and of faculty of arts and sciences at Yale University. He is a Finnish professor at the Yale Institute for Social and Policy Studies, Yale Alzheimer's Disease Research Center, Yale Center for Climate Change and Health, Yale McMinner Center for International and Area Studies, the Yale Institute for Network Science, and a faculty advisor of the Yale-China Association. He is a Claude D. Pepper Scholar at Yale Claude D. Pepper Older Americans Independent Center. He teaches U.S.-China health systems at Yale. He obtained a PhD in applied economics from Cornell University. His research integrates causal inferences, machine learning, and epidemiological approaches, and focuses on improving public policies on population aging, life cause health, and global health systems. His research projects, funded by public and private funding sources, has been published in major science, economics, public health, and medical journals, resulting in more than 100 peer-reviewed publications, such as Proceedings of the National Academy of Sciences, Nonsense Plus Medicine, Nonsense Public Health, Journal of Environmental Economics and Management, Environmental Health Perspectives, Social Sciences in Medicine, and American Journal of Agricultural Economics. These studies have been widely covered over 1,000 times in popular media worldwide. He is a commentator at BBC, Bloomberg, CNN, and CGTN. Also, his work has been recognized through numerous awards, including the Best China Paper from the Agricultural and Applied Economics Association, the George Warner Award, the McMinner Faculty Research Award, the Capful Award, and awards from the National Institute of Health. His timely and rigorous economic evaluations on the COVID-19 pandemic won the Kuznets Prize. Dr. Chen is a consultant at the United Nations Research Panel at the ICA Institute of Labor Economics, cluster head at Environment and Human Capital at the Global Labor Organization, former president of China Health Policy and Management Society, Butner Minions Scholar at the National Institute on Aging. He reviews research grants for the NSF, the NIH, and the United Nations research institutions. So it's very delightful to welcome Professor Chen.
Thank you very much, Dr. Huang, for your kind introduction, and thank you everyone for joining. So today in the lesson hour time, so I would like to introduce, I think, one of our most important diseases in the history of medicine, which is Alzheimer's disease. And as people are getting older, and we are more and more faced with such kind of threats, and it's very costly, and it costs not only to the patients but the family and the community. So I would like to show the screen here. Yeah, so I hope to present some findings, summarize some of the exciting areas, and then open up for more conversations. But feel free to ask clarification questions during my talk. So here, let me switch. Yeah, could you see the full screen now?
Yeah.
Okay, good. So we try to look at the addressing the disparities in cognitive aging, which definitely includes all kinds of neural uh, diseases like neurodegenerative disease like dementia, Alzheimer's disease, and as economists by training, how we can contribute. So we all start from here. The global population has been aging very fast. No matter where we are, no matter what kind of society we are in. And you see, if even African countries, they are younger, but you see a shrinking size of the younger generation, but more people getting older and people are living longer. So people living longer means that they will have more and more threat of chronic conditions, uh, not uh, uh, not only the infectious disease, but also chronic conditions. And as we grow even older, then there will be even more threats from like neural diseases like Alzheimer's disease and dementia. If we look at America, people above age 85, so 1/3 of people are having dementia. So that's a very large proportion of people. And with the shrinking younger generation and the bigger share of the older population, it means that we will have fewer people to take care of the older persons. That will be another challenge because we know like dementia, Alzheimer's disease, those diseases really require intensive care. And here shows a patient's portrait starting from when he was uh, very healthy cognitively, but starting from 1990s, early 1990s, he had trouble with memory, with the cognitive functioning. So you say every year he was doing a portrait of himself, but gradually they lose some of his mind and gradually lose all kinds of details to those portraits. So this is exactly what has been happening for the aging population around the world. So they have memory issue, cognitive ability issue, decision making, and they have really worse mental health and other things. And they could even not remember their family members. So, and we're talking about this disease called dementia, and the global prevalence rate is very high. This was like 20 years ago, but by 2000, but you see that after 50 years, by 2050, this is the prevalence rate, and each dot represents 100,000 cases of dementia. You see it's becoming more and more. And in some countries, incidence rate is reducing, including in America, it's stabilizing. But since in the US, we have a bigger size of the older population, so that means overall, we have more and more people are having this issue. And we're not only talking about people starting to having the dementia or Alzheimer's disease, but we're talking about even more people because before people develop dementia, there would be a stage called a mild cognitive impairment, which starts with some memory issue. But there's even longer stage, which is called a preclinical stage, which people start to develop some issue with their brain. For example, their nerves cells die, and some of the proteins like amyloid accumulates in the brain, which impair the functioning of the brain. So it will take very long. So when we talk about dementia, it's already a late stage, but it started to affect people like decades ago. I will show some evidence to show that. So this means that it's relevant to every one of us because that symptom, this kind of disease started like now even in 30s, 40s, but it gets worsened until the end of life. And the healthcare system is not doing a great job because half of the people who have dementia are skipped from the healthcare system, for example, due to their concern, economic concern. So they do not have money to pay out of pocket. The Medicare may not cover all of them. And the people below age 65, we know that they do not have Medicare coverage. So that means they have a budget concern. And also there's some stigma issue, for example, especially for the ethnic and racial minorities. So they try to avoid the social stigma, so they are not getting treated in the hospital. So we are missing like 50% of people if we're only looking at the healthcare data. And for those who are luckily go to the healthcare system, you say that they still have trouble. This is like the department by each of the health department. And there are two bars for each disease. One is whether the problem is a priority from the perspective of patients. The other is whether the physicians were able to address this issue. And you see the largest gap occurs between for the memory problems. That means that most of the healthcare systems, health facilities are not able to address people's memory issues. So this is the survey in America. And not only healthcare, but also people may talk about drugs and therapeutics, whether they can help mitigate the threat of this disease. But unfortunately, no. In the last 20 years, there have been like around 400 clinical trials, but all of them failed. I would say all of them. The one only exception is the recent one. Many of you know that FDA had a very controversial fast approval of a new kind of drug, which is said to relieve the symptom of this disease. But this is still not a disease-modifying type of treatment. So that means it will not slow or stop the progression of the disease. So because the issue is that so far in the medical science, there's no consensus about the real underlying the course of this disease, whether it is because of something wrong in the brain, or even some people think infections in the body may affect the development of this disease. So even for the brain type of hypothesis, there are different type of protein being studied to show that they can accelerate the progression of this disease. For example, amyloid or tau. So those are all the proteins in the brain. So they have different theories, but no consensus. So with this happening, we will say that the Alzheimer's disease may not be, even if eventually we will have a effective drug, but it will be very costly because, as you know, like more than 400 already failed. So the risk is very high. The pharmaceutical industry has to bear those risks. So the pricing will be very high, unaffordable to most of the people, even in America. So, but why, talking about the feature, the characteristics of this disease, why economists should be interested, and what are some key research areas I would like to introduce. And the first thing, when we talk about economics, we talk about estimation of socio-economic costs, right? Because this disease have several components of major costs. The first is, of course, the health, the medical costs, the diagnosis, symptom treatment, research and development of drugs. The second part is the social cost. Unlike many other diseases, so this disease is requiring more of long-term care or informal care or formal care in institutions at home, so which require a very large cost. And actually, if you look at the figure on the right side, you will see that a large proportion of the costs are about those social costs and the informal care costs. Those costs are much beyond, like larger than the healthcare costs, because as I was mentioning just the slide before, there was no effective treatment. So that's why the medical cost, the drug cost is very minimal. So most of common cost is about informal care cost and the social cost. And there's another cost, which is productivity cost. Because as we know, when people develop the cognitive issue, they have trouble to work and they have trouble to like function and make decisions in their daily life. So that's another productivity kind of loss. So there are several dimensions. And according to estimate now, uh, today, on average, annually, in America, the cost, including those four components, are about 100 billion US dollars. But if we look at by 2050, the projection, we also do some projections and shows that it will increase to 140 billion US dollars per year by 2050 because we have more people are diagnosing such kind of disease. And if we look at the people, an individual who is aging at 70 years old, and if we calculate for this individual was diagnosed Alzheimer's disease, one type of the dementia, and if we calculate the lifetime healthcare costs for the remaining life, it will be about 712,000 US dollars. But if we compare other people at age 70 without such disease, the average cost would be like 250,000. So it's like almost 3 times as high as a normal older person at age 70. But if this is like cumulative, like remaining lifetime cost, but if we look at annual cost, there's different calculations, but this is most well known by economist Michael Hurd in 2014, and they calculate that based on their model and the representative sample of the American population. If we add up the medical cost, no matter whether it's covered by Medicare or out of pocket, and also the formal home care as well as informal home care, in different scenarios, the cost will range from like 56,000 to 64,000 per year per person, so which is very costly. And this is not accounting for the most recent drug, which was approved by FDA, which costs another like 50,000 or more than 50,000. That means if you implement that drug, on average, individuals will cost around 110,000 on average, which is unaffordable for most of the people. And if we look at the reason of the cause of deaths in the last 20 years, this is for American again, using the National Center for Health Statistics, you will see that most of the diseases, the death rate is reducing, including HIV, including stroke, including heart disease. But for Alzheimer's disease, it's rising very quickly, more than 140%. And if we look at the global annual cost, there was also an estimate by the US Alzheimer's Society Association. They show that the global annual cost is about 1 trillion US dollars. So this is very high cost. So why economists should be interested? The first thing, as I was giving you, those numbers is very striking number. So there's a large tangible, intangible social costs about caregiving, social, emotional, mental, financial, medical cost, and productivity loss. And the second thing is about economics, essentially is about incentive. So we started incentive from both supply side and the demand side. The one issue to prevent people to have like really in debt about this the spending of this disease is to have the health insurance coverage. But as we know, this disease, I showed you that it happened for decades. So there's no single insurance having such kind of incentive to prevent or cover people for that kind of disease, because we know that the U.S. healthcare system is very fragmented. So we have employer-based sponsored health insurance. When we retire, we can have Medicare, and sometimes some people also have Medicaid. But those insurance, people are switching. You don't have like a long-term insurance that have such incentive to cover people against this type of risk. And also, traditionally, we know that healthcare system is highly information asymmetric. So patients, providers, and peers, they know very different things and they have different information. So that also causing trouble about treating this disease. And there's another third aspect about why economics should be interested, because traditionally economists were looking at maximizing the benefit or the utility based on the budget constraint. Everyone have a budget constraint based on your assets, your wealth, or your income. But faced with this disease, there's another new constraint, which is cognition constraint. We cannot make our decisions anymore. We need decision-making tools, assistance to help us. So this means there's a cognition constraint adding to the economic model. So what's the consequence of having trouble with cognition, and how that affect well-being? There are a growing number of studies. For example, people showing that when you have a cognition issue, you people tend to have trouble with deciding when to retire. The retirement timing could mean quite a lot for people's resources after retirement. As we know that U.S. health, the retirement system, if you retire early, you may lose some of the benefits, and retirement itself may also matter to your health. For example, matter to people's cognitive health, mental health, physical health. And also, pension claim is also a decision-making issue. And in America and many other countries, when to claim the pension is a real high stakes choice, because in America, for example, if you retire a few months earlier, your social security income could cut by 1/3 up to 1/3. So this is really a decision-making process, really need cognitive ability. But by the time of retirement, the risk of cognitive aging, dementia is getting larger than in younger age or in the middle age. And also, there are some studies showing that when you have a cognitive issue, you have trouble with saving, investment, financial mistakes, all those things, and or even subject to financial exploitation. So I will show one example about that. And also, you may have health issue. So if for people, that's our study. We show that when people have a memory issue, they tend to have a trouble to maintain their preventive care. So they can skip the preventive care, like measurement of diabetes, hypertension. And also that is a really big toll towards racial and ethnic minorities, because we find in American sample, the Black Americans, Hispanics are more likely to skip those necessary preventive care when they are start to have the memory issue. And also people may have hospitalization. Many studies show that when you have a cognitive issue, you tend to be hospitalized for different kind of reason, because you cannot maintain a healthy diet. You cannot make correct decisions in your daily life. So a lot of those hospitalizations are avoidable, but people were not able to keep themselves away from the hospitals due to all kind of bad decisions. This is just showing you one example. This is America survey for older persons above age 50. So it's actually mid-age to older persons. 1/3 of them having trouble with the financial fraud. For example, 30% of them had account being attempted without permission in the last 5 years. And there's also they also had suffering from the fraud in the past 5 years, around 35%, more than 1/3 of them. That's a very big trouble. And for those who develop dementia, there's a recent study showing by Johns Hopkins University research team showing that when you have a dementia, you tend to miss credit payment, and which can cause financial trouble and subprime credit score and those. And strikingly, this doesn't only happen when you have dementia, but a few years before that. So for example, here the left figure shows that up to 6 years before you diagnose dementia, people start to have trouble to keep paying their credit card. So which cause financial havoc havoc to their individuals. And this is our study, as I was already mentioning, when people are having trouble with memory, they tend to skip preventive care. This table is looking at memory-related diagnosis. We find overall people, when they have memory issue, start to have memory issue, they tend to skip those memory related diagnosis, which make them unprepared for the future. And this is true especially for non-white Americans. So we see that white Americans may respond by uh, calling their primary care doctors, but the non-whites are not doing so. And people with lower education tend to skip more, and people without spouse, people without children living closer to them also suffer from these things. So it's a issue with like financial decision making, health care decision making, all kinds of decision makings that are very important to their well-being. And the second part, a segment of the reason and the key research areas for economists to contribute to this field is that, as we know, there are more than 400 drug clinical tests being already failed. That means the risk is very high. So eventually, if we have one drug successful, the pricing will be very high. The risk and the pricing are usually matching each other. So how to make sure that people can afford this? We cannot let the ordinary public to pay as much as Bill Gates will be paying. So there has to be some pricing mechanism to achieve the market equilibrium. That means richer people are willing to pay more and will pay more, and the lower income people can pay less, but still afford such kind of drugs if there is. And also, when the Medicare, Medicaid, all this insurance, the payers decide whether to cover those drugs, they need to also have some cost-effective assessment whether this drug should be reimbursed and what's the reimbursement rate for those drugs. So special consideration should be taken, for example, to consider about externalities. That means the cost is not only to the patient themselves, but the family and the society. So that's why it's very important to think about the costs, which is bigger than we thought. So when we decide whether to cover and how much to cover this drug in the health insurance. And also we know that since this is a so risky kind of initiative, so the private sector will not have the strong incentive to invest. So which will require more public good provision from the government agencies like the NIH, NSF to invest in basic science. Because so far we don't have a real understanding about which pathways really lead to dementia. For example, here I just list 4 of the major ones. The vascular pathways. If you have heart disease, you are more likely to develop dementia. So this is one channel. The other is inflammation, and the third amyloid, tau, and also there's also a biological aging pathways. So those things are something economic theory and economic evaluations can help. And also the last one of this segment is about addressing disparities. So economic research have been very interested in understanding disparities in the cognitive aging and the quality of care, because eventually we have to level the play field to have a more of social equity and health equity. And thinking about those equity disparity issue, you will see that this disease is especially of high risk to African America and compared to white America, and also of high risk to the Hispanics. So they are of different risk and for different kind of reasons. I will also touch about this issue later when we think about it. It's not only about like epigenetic issue, but sometimes it's also about like a life course issue, because people tend to be exposed to this risk early in their life, which accumulate their risk until later life. They are more likely to develop this disease. We need to address this. And for the medical innovation, we need to consider about those disparity, because the most recent drug approval, as I was mentioning, FDA's Aduhelm, they were like doing this clinical trials using very small proportion of high-risk population, which is Black or African American. You see that only 0.7%, but majority of the subjects attending such a clinical trial are white Americans. They are of very low risk, and Asian Americans also very low risk. So the clinical trials and the study of this disease and the social disparity, health disparity, we need to account for those really high risk group to take account of this factor into the drug research and development. And talking about the disparities, not only the disparities is not only about the patients, but also the caregiver. The caregiver are mostly their family members, and especially if you compare males and females, females are the main caregiver, and when you are the main caregiver, you suffer most from this in terms of their labor market, in terms of mental illness, and this is a very tremendous mental burden to take care of people for a very long time. Here you see the length of care. 86% have at least 1 year. 50% need to take care of their family members for more than 4 years. So and some people may even take care of the patients in the family for up to 20 years. So it's really a long-term care setting. So in order to address this disparity issue, we need to think about providing more favorable policy for caregivers. For example, the paid leave to take care of the family members. And such policies have been in place in most of the European countries. Like one country I would like to mention, pay special attention is Belgium. They allow like up to 12 months to take care of the family members. But most of the European countries, OECD countries, they have such kind of arrangement. But some other countries also have the policies to subsidize their caregiver, the care receivers, for them to find and keep their informal caregivers. So that's another type of policy. But unfortunately, in America, this is really in need, and nationally there's no universal policy to cover paid family leave to take care of the patients. And we see some states are implementing. I think the earliest ones are California, New York State, those are the two, and Rhode Island. And starting from this year, the state I live in, Connecticut, and we have enact and started such benefits to take care of the, which allow, I believe, the family members to take care of the sick patients for about half a year, and with the payment from their employers. But the majority of the states in America is without any kind of such paid family leave policy. Yeah. Any question before I talk to the last part of things I would like to cover? I think it's a good point to ask any questions you may have. Okay, so let me keep on. Yeah, any questions?
I just wondering, just now you mentioned like for different reasons to lead to the disparity. So they are the same, like same important, or actually it's different important?
Yeah, that's a great question. So I actually would like to cover this in the third part. So when I talk about long-term effect, I will discuss this issue. We have some studies to show the long-term effect, all kinds of early life factors, midlife factors, and there are some studies in the literature for American and for other populations. So I will discuss this. So just hold on a few minutes. Okay, so let me just mention the third, and I think it's the last part of the the issues economists can contribute, and I think very important. One is we talk about the caregiving burden, so we need to not only evaluate the loss to the patients, but the caregiver. So the caregiver, we can evaluate their cost to their labor market performance, their retirement security implementation, because eventually they will miss part of their job market years, which will have a toll toward their retirement savings and all those things. And labor market can also be shocked as a result of caregiving. And economists have been have very efficient tools to assess the causal mechanism. This disease, when we need to think about how policy to address to reduce the prevalence of the disease, or to think about how to intervene to benefit the caregivers and the patients, we really need to think about whether it is causal. So we need to evaluate how effective each channel would be. So economists have been doing some kind of such work to deal with this. I will talk about this in the next few slides. And also economists are using this causal mechanism to study the long-term effect. So this is very important because the dementia is unlike infectious disease. It's not happening on the day when it shows symptoms, but the risk has been accumulating over the life cycle. So that's why economists have been using like natural experiment, such different kind of policies to evaluate the effect. So there are different kind of reasons, but I can skip here. I just want to say there are different models, different theories to show that the risk is really accumulating in the life course. So all this literature I show are discussing the mechanism that linking early life risks and the later life cognitive aging. So if we want to have a more cost-effective interventions, we need to understand those models, those risks. And a very well-known economist, James Heckman, had one well-accepted called the Heckman curve, which actually calculated return to $1 investment in different stage of life course. And his theory also shows that if you invest in early life, it will significantly reduce the health risk later in the life. Not only health risk, in his study, he also looked at the labor market performance. And more recently, there's the Nathan Henry, a Harvard professor, was looking at more than 100 social programs in America and showing that the very similar conclusion compared to James Heckman. The social programs in early life like Head Start, which is a preschool program to stimulate the development of children. Those are having long-term effect. So through those kind of studies, we just try to show that we need to intervene in earlier life instead of waiting until the mid-age or later age to address the dementia, because that would be too late and very costly. So this is one study using Kaiser data, insurance data, to look at people born in different places. When they were born in high stroke mortality states, and they are controlling for all major other characteristics during their life course, they show that the place of birth really mattered to their dementia incidence in later life. You see a significant difference. And also our recent study using the Chinese sample also show that if you were born to the family with different kind of socioeconomic status, your mothers with low education compared to with high education, or your and even the relationship with parents really matter to the long-term cognitive aging for the children. And this study, we link the data for children before age 10 to their health outcome data, especially cognitive measures after age 65. So it actually is more than half a century apart from each other. And you see the clear link between people with more advantages early childhood and the later cognitive ability in later life. And this is, I think, the thing I want to highlight. This is from a Lancet commission report NASET has been releasing this commission report for dementia for many years, and every other year there's a report discussing about the life course risks. I think Dr. Huang was asking about whether the risk factors are equally important. Some are more important than the others. According to this report, they show that the education really matters very much, the education attainment. And after that, in midlife, for example, hearing loss, traumatic brain injury, hypertension, alcohol use, obesity matters. And in later life, smokers tend to have higher risk, or mentally depressed people having high risk, or social isolation really matters. For example, we can think about during the COVID-19, the acceleration of the worsening of Alzheimer's disease for people living in the nursing homes. And the physical inability is a risk factor. And most recently, the NASET Commission report adding the air pollution into this list. Air pollution is a big risk factors. There are many studies from environmental science, from economics literature, and diabetes. And those altogether can explain about like 40%. So this is something very important. We still don't know like 60% of the risk or the variation in the dementia in old age. So far, the observable risk factors could explain only 40%. But that's something, if we take actions and we have public policies to address those issues, we potentially can reduce 40% of this risk. And the economic study have been looking, as I was mentioning, very capable of using natural experiment to evaluate the different way to intervene. For example, economic evaluations have been looking at education. Since here, the NASET report shows that education is very important. But our study, I just showed you earlier, is looking at the things happen before education. So that was missing in the NASET Commission report. So we highly argue for even earlier life intervention in the early stages of life. But for the existing evaluations in economics literature have been like using variations in schooling policies across countries. For example, in England, the schooling system have been changing the minimum school living age in England from 14 to 15, which increased the education level for average students, which will have consequences. And this policy was very early. I believe it's in the 1940s. So those people are already in their very old age. So that's why there are some studies linking those education reform with the cognitive ability. So in the interest of time, I'm not talking into details, but there are a few research papers, very rigorous evaluations to show the benefits of educational reform. And also in Turkey, there's the extension of compulsory schooling from 5 to 8 years in 1997. And in China, there was a compulsory schooling law, which also increased schooling years. And also in Indonesia, similar policies. In America, also there's variation in the state compulsory school law in America. Those are the education reforms have been studied in the economic literature and already show a strong benefit to the cognitive ability in old age, and can even reduce the progression or slow down the progression of dementia. So that's consistent with our observation in America that although the prevalence is higher and higher for dementia, but if you look at the incidence, so the incremental number of people who are newly having this dementia issue, you see this growth rate is slowing down. So which means that there will be a very important window of opportunity to intervene through education system. But beyond that, our study, in the interest of time, I'm not having much time to discuss our other results, other studies. We have a bunch of studies looking at the different early life factors, including not only education, but things happen before education, the early learning at home, like how many how much time your mother can read to you or to educate you, have the conversation with you in the daily life. Those things matter even before the education. So those we call the early educational environment. Those really matters. And some other things more studied in the literature, not only economics but the epidemiology, is looking at given that this is a risk already formed in midlife, how we intervene. So, for example, some studies showing that using cognitive training and diabetes control and the hypertension control, those measures, public health campaigns really may help to slow down or mitigate the risk of dementia. So those are things being well studied. Some of the policies I've been discussing are like using the randomized control trial. For example, the cognitive training has been showing to slow down the cognitive aging. So very helpful program that could slow down the development. So the last slide, so I would like to say that since this disease happened during decades, so we not only talk about end of life, people already have very high rate of dementia, but also in the moderate disease stage, early disease stage, and at risk, and even well population, we can use economic science to identify the risk and the group of people with higher risk, and to have a more effective policy towards those groups to slow down if we are not able to avoid such disease. But if we can slow down the disease, delay the onset of the disease, even for 1 year or 2 years, it will be hugely beneficial to the healthcare and to the society. And we have been talking about education policy, labor policy, even housing, affordable housing, community service, public health, and healthcare. Those things matter differently in different stage. Here I also listed one, but I don't have much time to discuss. The science and technology policy actually really matter because we know, as I showed in the beginning, the shrinking younger age population and the enlarged older population means that we will have fewer younger people to take care of the older people. So the automation, the robots, those new development in the science technology really will enhance the well-being of people who really need care in the future. I think Japan has been innovating this sector quite much, and a lot to learn from Japan and other fast aging societies. And I think that's things I want to introduce, and look forward to any questions you may have.
Thank Professor Chen's very interesting and comprehensive introducing about addressing the disparity in cognitive aging, especially about how related the economist research areas. So currently, we open to the question to see for any questions. So I guess I can. I will start for the question. Is just now you mentioned the large area is related to the labor markets is the care given. So, but considered, it seems considered about the stage from like early to
Yeah.
middle to the late life stage. Seems that the lifestyle playing an
Yeah,
important
right.
role.
Right.
So then how actually, besides the care given,
Yeah.
other related labels may play a role in this process?
Yeah, I think the risk start to accumulate when the brain development develop very fast. As we know, in childhood, the brain development was very fast in childhood. So it's very important to ensure more equitable quality of education at home and in the school. So that where like we call the level of the play field. or we call it equality of opportunity, because those are the inequalities in the early stage of life really have a long-term effect. The reason there are different channels, for example, the discrimination against the certain groups will have like inflammation causing struggle and stress in the brain, and the inflammation can accumulate over the life cycle, which cause a higher um, risk of dementia and other cognitive illness in later life. That channel has been studied quite a lot and being approved in much of the literature. So and the stress, discrimination, those are not only in the home at home, but also in the community, and also like high crime rate uh, through poor provision of public good. Like I have been studying Flint water crisis has been causing the newborn babies having higher than average like lead in the blood. So this will have a long-term cumulative effect. I just mentioned one of the things, like the public good provision, the drinking water, the affordable housing, and those things happening in early life really matter. And in the labor market also that's the case. So if there's more discrimination, like inequity in the payment, and those we sometimes we call the structural inequity in the society, which will have health consequence. So economists have been studying this quite much, and the economists have been looking at this social issue not from the single generation perspective. They look at the intergenerational. So I think that's very powerful. They look at like the discrimination against the parents, how that transmit to the next generation and affect the long-term well-being. And also sometimes they look at the positive side. They look at the better policies in intergenerational. For example, if you give parents, the lower income parents, Medicaid coverage, the recent economic studies show the benefits across generations about the health and well-being to the next generations, and until they are going to the labor market, they show the next generations will have a higher wage in the salary in the labor market. So those benefits can accumulate long term, and which I think very important, because when you think about the policy and the cost and benefit. So we tend to think about short term, but if we are accounting for those spillover effect, positive spillover to the next generation, maybe that will change the policy measures, and maybe some policies can be more like um, uh, more so we can have a broader policies and to cover more people like with lower income, for example, in this case, Medicaid. And another thing, for example, the air pollution. I talked about the drinking water, talk about um, Medicaid, but also if we look at another social policy really important in 1970s, Clean Air Act, and that significantly reduced the pollution level across America. And many economic studies show that the effect accumulates towards the next generation. For example, if you look at the low birth weight babies for advantaged mothers and disadvantaged mothers, so their gap is shrinking after 1970. So that was very stringent policy, and the higher birth weight for disadvantaged groups will eventually benefit them, because in economics literature, low birth weight is single most important indicator of human capital in the long term. So if they reduce the risk of low birth weight in early life, it will have a benefit, huge benefit to the labor market and to the well-being in the long term. So those things have been studied quite a lot, and the economists even have been measuring the return to 1 gram increase in birth weight, especially for the low income groups. Their slight increase in the low birth weight will be of large effect in the long term. And including the Flint, I was discussing the Flint water crisis also reduced, and that's our most recent study. We show that it reduced the birth weight by about 33 gram per baby born to the Flint city. But this is like an average effect. If you look at the benefit to the Black Americans, it's much bigger because they are more affected. If we look at the grocery shopping data after the Flint water crisis, more advantaged groups they can afford to buy the bottled water, so they tend to avoid those shocks. But for the disadvantaged mothers, they are not afford to have adaptations or reactions to avoid such kind of pollution. So they are more affected. And we're talking about Flint, but Flint is one of uh, estimated like 2,000 American cities with lead in the water problem because of the aging pipes. So I think this is a nationwide problem. So if we think about all these policies that have an effect in the early stage of life, then we can think about come up with a large number of them. And so economists have been like, as I was showing the Nathan Henry study, he was comparing the return to $1 in investment for more than 100 US social policies during the last few decades. And he shows that those benefits are usually much larger than the cost. For example, the Head Start, which is a preschool program, the benefit cost ratio is about 8. That means $1 investment will have more than $8 return. So those are huge return. So if you think, yeah, not only education, environmental policy, housing, employment, those are all some potential policies we need to evaluate and strengthen.
Thank you for the very detailed answers. I just see if any questions. Questions from
Yeah.
Jonathan Rosenberger. So the political challenges indicated the paradigm those faced by advocates of ecological and social justice and environmental sustainable development. The essential tensions between short-term budgetary and political cycle and the localized cost and long-term global benefits.
Right.
So thanks for giving us another way to argue for fundamental change.
Yeah, thank you so much for this comment. Yeah, indeed, I think economic study can complement the well-known like medical studies and epidemiology studies in the sense that it looks at the long term. Although politicians may not care about the very long-term effect, but if you not only care about yourself, self's political career, but if you care about your parties, then you will take a long view. I think you will take that into consideration. If the time horizon is widened, it will fundamentally change our cost-effective analysis of much of the policies. And I think in that sense, many countries, including the US, can strengthen their central government budget. Although I know this is not a very popular argument in America, but we have to do something to strong measures to increase the central government budget. For example, healthcare. So far, I think the Medicare has been like mostly run and financed by the federal government, but Medicaid is left to each state, and we know that many of the states have not expanded Medicaid, and those things I think need to strengthen the budget, and for some public health issues, medical issues, those have a strong argument because this is a strongly a public good, and local government may not have incentive to invest more. So that has to be left to the federal government to do so. And I just want to say one more. So not only America, because I have been studying many countries' health issues. Let's say for China, China also has a similar issue. The only 1% of the public health spending was done by the central government. 99% are left to provincial level government. So rich provinces have more incentive to invest and they have more surplus. So China also have very similar issues about strengthening their central government. So in that sense, otherwise it will be very large health issues and will have a long-term consequence. So that's why you see that if you leave all the things to the local level, so it means that those public sector will be more profit driven because they have to balance their budget. They consider about the short-term benefit and cost, which may not be consistent with the longer-term well-being of the public. So you have to reform. So coincidentally, U.S. and China are two countries with very similar hospital-centric public health system because their investment from the government is very minimal. So they have to be profit driven. When you have a profit driven system, you tend to have a very weak primary care system. And we know that primary care system is vital to the population health. So I think a lot of those observations may be interpreted when you think about like the budget share like provided by the central government, local government, in order to have a more pro-population policy. The federal government has to step in because the federal government will take a longer-term view about the interest and the well-being at the nationwide for a longer time period, instead of leave all those public sector issues with the local government. Yeah.
For thought,
Someone
questions? Yeah.
Yeah, please.
Yeah, you mute yourself. You need to unmute yourself.
Okay, thank you, Professor Chen. I do have a question here.
Sure.
In the slide, there's a slide that you show in the dementia and Alzheimer's was high in African American population here in the state.
Indeed.
And when I see the data of Africa, it was very low and was high in China. Is it because there is lack of data in Africa, or why is it?
You mean, yeah, we compare different groups, African Americans, Hispanics, White Americans, and Asian Americans, right?
Yes.
So, yeah, African Americans, according to the national statistics, the risk is about 2.5 times as high as White Americans. And the Hispanic Americans is in the middle. The risk is lower than African American, but higher than White American. The major reason is about education. The education is single most important protective factor against dementia, because we know that with more education, your brain has more reserve, can be more protective against dementia. But we know that due to different kind of reasons, discrimination against even segregation many decades ago, right? So make the education system very unequal between groups. For example, African Americans, their school quality, although their years of education could be similar in some cases to white counterpart, but their quality of education is low. So those are dragging African Americans behind. And just the other day, I was in the talk by Agnes Deaton and Annie Case, who are both economists at Princeton University. They give a talk about they call the death of despair. So in American opioid crisis, all these crises, and they find that race and ethnicity is a major predictor. So that's not surprising. But what's surprising finding is that education is becoming more important than race and ethnicity to predict health outcomes, mortality and suicide, opioid overdose, those issues. So education, I mean, from their study also shows that education, I mean, the inequality of education, no matter whether the year of education or quality, is becoming a driving force of a lot of health issues. So that's why if we look at Americans, white Americans, the risk of dementia is actually reducing. But if you put all Americans together, no matter which race ethnic groups, the overall risk is still increasing because there's a growing divergence between among those groups. Yeah.
We have another question from Matt Shapiro. The off-topic later, is there any impact of the long-term care insurance market on the findings you have reported here. I ask because I have recently been told that LTC plans are moving towards insolvency.
Right.
Long-term implications of this for the United States.
Right. This is a great question. The insolvency not only apply to long-term care system in America. The long-term care insurance, especially the which covers catastrophic health risks, those are lacking in America. Medicare, Medicaid only cover part of it, but it's not in the pace consistent with the rising disease burden, especially Alzheimer. As I was mentioning, if you count for the drug use, it will be like around 100,000 US dollars per year per person, which is unaffordable for majority of Americans. So that's a big issue. The long-term care system, LTC, has to be built in America. Actually, it's lacking. And another, I would add, the insolvency not only apply to long-term care, but also the Social Security income system in America will be insolvent in 15 years. So the most recent calculation by the Congress Budget Office showing that by 2034, even 1 year ago, 2 years ago, before the COVID, it was like 2035. Now it like can get closer 1 year to 2034. By that year, the Social Security income system will be insolvent. So that means, according to their estimate, all people who claim the Social Security income will cut on average by 22% after the retirement. So the income resources will be greatly reduced as a result of this insolvency in the Social Security system as well. So I think those are all things need a strong steps by the federal government to step in.
Thank you. So kind of related, but not. I'm not sure it's related to this question. Is like for the insurance market compared to just now you compare U.S. to China.
Yeah.
So you mentioned that there's a similarity between U.S. and China. Is the central government actually is in charge of very little, and it's in charge of for like a provincial level. So and also so that's how like disparities. But do you think it's because of the health systems reforms? Because China before it's not that system, but currently it's more like similar like US will go to this kind of insurance company instead of by the public welfare systems.
Yeah, indeed. But for in both countries, health systems are very decentralized. Yeah, but for different reasons. For America, is more pro-market, pro-choice. So that's why the government, central government, do not have a strong hand to intervene in all kinds of things. This is due to the culture, the social norm in America. In China, that's because of the marketization, the economic reform starting from 1980s. The government really want to pay more attention to the budget and the physical revenue. So they connect all the revenue to the central government, but they try to leave all the things about spending to the local government. So that's why healthcare is a big spending. So they left it to the local market in order to improve the financial or the physical budget of the Chinese central government. So that's the arrangement until today. So they lack a central budget for healthcare, and in America, very similar thing. So that's why you see that the healthcare sector is very much profit driven in both countries. I was mentioning U.S.-China similarities in this sense because I compare to European countries. In many of the European countries, they have a much stronger the federal government or central government in the health sector, and also the pension system. But in America, it is very market driven, and also that's the case in China. So I've been studying around 40 countries compare with those health system, pension system, because the National Institute of Health in America, they have been collecting data from those 40 countries, ranging from very developed countries like American, OECD, European countries, but also like less developed countries like Mexico, like India. So we have those data. We keep monitoring different health system and pension systems. Yeah, so I think that's something. If I use one word, is to describe the difference is U.S. and China system are very decentralized, but European system are more centralized in terms of social welfare system. Yeah.
So, do you have time for one more question?
Oh, sure, no problem.
So I just wondering, like, since you already have research for so many countries, and also you mentioned actually for the like Japan, they have very good fostering systems. So I'm wondering, like, for these Alzheimer or dementias, they are related to the people's life expectancy. So which means that when people they are older, then they have a high probability to get this disease. Then how actually like Japan did in this system they did good is because their policy, as you mentioned, that because they have because the policy is long term. In fact, so it's because they started the policy earlier. Or is because they are society, some factors from society.
I think that's because Japan is aging even faster than China. So with the faster aging society, they have to come up with the care to meet the demand of care. So in Japan, the life expectancy is almost 10 years higher than in China. And for Alzheimer's disease, dementia, they are not reducing life expectancy. Actually, people with those diseases are living longer.
Oh.
Yeah, because it's not like they cannot die from heart attack. So they just cannot remember anyone. So they just need care. They can. So that's the trouble with the world global aging population. With this disease, it's unlike infectious disease, unlike chronic disease. Eventually, they will die, accelerate their deaths after a certain age. But this disease is prolong people's life. So that's the trouble. So. And the trouble comes from when you really live longer, you need care. And also when you live longer, you need to rebalance your spending and your income. So the income comes from pension. So the pension system is becoming insolvent because people are living longer. And the care system is unsustainable because of lower fertility. Fewer people are taking care of older person. So I think that comes from these two parts. The issue. And Japan was realizing this is unsustainable. No people can take care of the elder persons. So that's why they developed like more automation, more robot and other things. Yeah. So it's more about their.
Oh, okay. So
yeah, and China will accelerate in their aging process. So that's why I think in recent years you can observe that China has been very active in the robot industry development. And this is right.
That's a very interesting topic and the areas actually we didn't it seems not mentioned yet. So using AI system or
the AI system, right. But I'm not quite optimistic that this can substitute people's care, because eventually the care is very complex. Robots can take some role, but not all of them. So I think, yeah. So,
but I'm sorry, I have one more question. So, but actually, the person have this disease different from other diseases because these persons they don't have memories. So
they just don't have memories and they cannot make their own decisions. They have trouble like eating, bathing, basic function. So if someone take care of them, they can live very long. So that's why you see that if Alzheimer patients can be well taken care of, they can live 15 years from the time when they.
But in that case, if they just need all these physical instead of emotion roles, why the robots or AI cannot take it?
Oh, they need the emotions because you know that those patients, although they forget everything, but there are some cases every day they will recover their memory for a little bit.
Oh, okay.
Just for an hour. They realize that why I stay here? I should live in my home. So they feel frustrated.
Oh, okay.
They are not like forever forget things. They forget things the majority of time. But there will be some time their minds are clear. So, but they realize that they are living in a place they don't really would like to live in. So that's why you see that the mood and the are not very good for the dementia patients. They tend to like beat others and they feel frustrated, all kinds of issues.
Okay.
So it's very difficult for the family members to take care of them because if you have any patient like in that mood and yeah, the whole family will be affected. So they have to live in the nursing home. And you see that in COVID, a larger proportion of people die in nursing home are dementia patients because there are very few people are taking care of them.
I see.
Yeah, the majority, like I see the number, 75% of the Alzheimer patients, dementia patients, eventually die in nursing homes.
Wow, that's
Because the
much.
family member no longer can care them.
That's
But for cancer patients, it's different. Like only 20% cancer patients die in the nursing home. Because cancer does not cause trouble to the other family members. But dementia will cause because people feel like unstable. They are very irritated and yeah, and they can cause harm to the other family members, and it really require very complex care system to take care of them. Yeah, it's very difficult, different.
I see.
Yeah, but eventually, I think that's the stage we are unfortunately in. Eventually, more and more people will die because of less of care due to dementia, but fewer people will die because of infectious disease or cancer. Because cancer eventually will be cured, but Alzheimer's disease is difficult because it's illness in the brain, and the brain is so much complex. Who knows how to cure the disease in the brain? So that's why I mentioned 400 clinical trials all failed, no success.
Oh,
And it's very expensive. Yeah.
I see.
Yeah. Okay.
Thank you so much. I
No
just
problem.
stop recording.